Welcome. My name is Emma James, Vice President of E-Learning Global, the BIE chapter for the 2025-2026 academic session. I'm here to welcome you to this tutorial session. The topic that will be explored with clarity and give you a deeper understanding, and not just to help you pass and improve your academic journey, but also give you confidence in your academic abilities. Once again, thank you for joining us. I hope you have a wonderful and insightful time.
Thank you, Lord, for the gift of today and the opportunity to learn. We ask as we begin this session, you guide us and grant us understanding. In Jesus' name, amen.
Hi everyone, my name is Efeke and I'm a medical student in Bensalauta University, and I'm here to lecture on part 2 of the abdomen, anatomy of the abdomen. So this video is brought to you by E-Learning Global. So very quickly before we start, let's say a short prayer. Our Father in heaven, we thank you for today. We thank you, Lord, for the gift of life. We thank you for the privilege to be gathered to learn. Lord, we pray and ask that you grant us wisdom, knowledge, and understanding, and an excellent spirit, that all we will do today is to serve as a positive impact in our lives. For in Jesus' name we have prayed. Amen. So, in the previous lecture, we did an introduction into the abdominal wall, and we looked at the osteology, the bones there. We looked at the layers of the abdominal wall. We looked at something that we call the inguinal canal. So, very quickly, let's look at the muscles of the abdominal wall. So, as I said before, the abdominal wall has an anterior and a posterior. So there's the posterior abdominal wall, there's the anterior abdominal wall. And this wall, unlike the thoracic cavity that has bones that also make it up to form the thoracic cage, for the abdomen, it has less bones and more muscles. And I said that there's two categories of muscles. In the anterior abdominal wall, there's the vertical muscles, the longitudinal muscles, and then there's the anterolateral group of muscles as well. And then for the posterior abdominal wall, we're going to be looking at four muscles. We have the quadratus lumborum, we have our psoas major, our psoas minor, and our iliacus. So let's get into it. For the muscles of the anterior abdominal wall, we said there's the ones located vertically in the midline, and these are the rectus abdominis and the pyramidalis. So for the rectus abdominis, actually, it has its origin from the pubic symphysis and from the pubic tubercle. Pubic symphysis and pubic tubercle are parts of a bone called pubis, which is related to the pelvic bone. Then it inserts upwards, so it inserts the costal cartilages of the fifth to seventh rib. It also inserts into what we call the linea alba. The linea alba is a white line. Linea alba. It's a white line, as the name implies. Linear meaning line, alba meaning like white. It's a white line that's located in the middle of the abdomen. It helps to serve as an attachment, or rather as a point of insertion for these muscles that form the anterior abdominal wall. So it attaches medially to the linea alba. So therefore we can say that the rectus abdominis muscle has two parts, a left part and a right part, or rather a right part and a left part, and then they are divided by the linea alba. So you can appreciate this linea alba in men that are toned or women that are toned, just anybody basically that has a toned abdomen that does all those planks and all of that. When you look at it, there's a line in the middle. That line is the linea alba. So the pyramidalis is also another muscle, and the pyramidalis is a very beautiful muscle in that it's very small and it is sometimes absent in a lot of people. I can remember when we did a cadaveric dissection on the anterior abdominal wall, the cadaver that dissected did not have a pyramidalis, while the other group's cadaver had a pyramidalis. So not everybody rather has a pyramidalis, and we can function without it. So the function of the pyramidalis is actually to tense the linea alba. So therefore it tells us that it inserts on the linea alba, and then its origin is also from the pubic bone, from the pubic crest and the pubic tubercle of the pubic bone, which are, as I've already said, are related to the pelvic bones. So these two muscles I talked about are anterior muscles that are longitudinal or vertical. And then we have three muscles that fall under the anterolateral group: external oblique, internal oblique, and transversus abdominis muscle. And these muscles actually related in the way they are oriented and in the way they are layered to the muscles that are in the intercostal spaces. So the same way we have the external intercostal muscle, internal intercostal muscle, and innermost intercostal muscle that form three layers. That's exactly the same way we have the external oblique, internal oblique, and the transversus abdominis. And the same way the external intercostal muscle moves from posteriorly anteriorly, that's the same way the external oblique also does. And the same way the fibers of the external intercostal muscle move from above downwards, meaning they move inferiorly. That's also the same way the fibers of the external oblique muscle move inferiorly. So it then tells us that its origin is superior and its insertion is inferior, just like the external intercostal muscle. So the external oblique muscle has its origin from the lower H ribs, which is rib 5 to 12. So from lower H ribs, that's where its origin is from. And of course, it inserts in the linea alba, as we've already said. This linea alba serves as a point of insertion for all these anterior abdominal wall muscles. So the linea alba, it also inserts inferiorly into the pubic symphysis, the pubic crest, into the pubic crest, the pubic tubercle, and then it also has a bit of insertion to the iliac crest. So if you remember when we were talking about the divisions, I mentioned a bone called the ilium that has a crest. So it also attaches anteriorly to the anterior portion of the iliac crest. Then we have the internal oblique muscle. The internal oblique muscle is the second layer. If I'm moving from superficial to deep, it's the second layer, and this one moves in the same direction of the internal intercostal muscle. So the same way the internal intercostal muscle moves from below downwards, so it moves superiorly and then it goes from anterior to posterior. That's also the same way the internal oblique muscle is oriented. So the internal oblique muscle therefore gets its origin from below and inserts upwards, while the external oblique muscle gets its origin from above and inserts downwards. So one is above downwards, external oblique, below upwards, internal oblique muscle. So for the internal oblique muscle, the internal oblique muscle has its origin from, again, the pubic symphysis, the pubic crest, pubic tubercle, pubic bone, and then it also goes upwards to insert into the costal cartilages of ribs 5 to 7. So yeah, that's all. And then of course it inserts medially at the linea alba. And so one thing you should notice that the muscles, some muscles are named according to how they are oriented. So for the external oblique and internal oblique, they are called oblique muscles because if you were to look at them, they don't have a straight path. So they are obliquely placed, ranging from the costal margins, the costal cartilages, the ribs, and they move diagonally. So that's why they are called oblique muscles. One is externally placed, one is internally placed, external and internal oblique muscles. So lastly, there's the transversus abdominis muscle, and this muscle forms the third layer, similar to the transversus thoracis or the innermost layer of the thoracic intercostal spaces. So for the transversus abdominis muscle, this muscle has its origin from the inferior surface of the ribs 10 and 12, and then it also inserts into the linea alba, and also it also inserts into the pubic crest, pubic tubercle. So that's all for the anterior abdominal muscles. And all the anterior abdominal muscles are supplied by anterior rami from T7 to T12. So rectus abdominis is supplied by T7 to T12, the anterior rami, spinal nerves, yes. And then pyramidalis is supplied by just T12 because it's located quite inferiorly. And external oblique and internal oblique are supplied by T7 to L1 actually. So they have up to L1, and then transversus abdominis as well, T7 to L1. So let's look at the posterior abdominal wall. So in the posterior abdominal wall, the intrinsic muscles that are related to the abdominal wall are quadratus lumborum, psoas major, psoas minor, and iliacus. So it doesn't mean that there are no other muscles here, but these muscles are more or less extrinsic muscles that we call muscles of the back, like erector spinae and the rest. So we're not going to look at them here because they are not related to the abdomen. So the quadratus lumborum is a muscle that is located quite, it is lateral to the psoas major. So I think it's better we start with psoas major. So psoas major is located medially, it has attachments to the vertebral column, the transverse processes of all our lumbar vertebra and the intervertebral disc between them. So the intervertebral disc between T12 and L1, between L1 and L2, between L2 and L3, between L3 and L4, that is, it serves as the point of origin for the psoas major muscle. And then the psoas major muscle actually is related to the iliacus muscle, in that in its insertion, the two muscles combine together to form what we call the iliopsoas muscle. So the iliopsoas muscle inserts into the lesser trochanter, and this muscle is important because it actually doesn't serve a function in the abdomen. Instead, it helps to flex or rotate, rather. It helps to rotate the lower limb. It helps to internally rotate or medially rotate the leg. Then we have our psoas minor. So the psoas minor is a smaller version. It's actually located anterior to the psoas major, and this one just has a short origin. So it is origin is between T12 to L1. So between T12 to L1 and the intervertebral disc that is also located there. And then it goes on to insert into what we call the iliopectineal line. So the iliopectineal line, or what we call the arcuate line, on the ilium of the pelvic bone, and then also on the pecten pubis, or the pectineal line of the pubis. So the psoas, okay, we'll talk about psoas major. The psoas minor, we've also talked about that. So for the iliacus now, iliacus is actually related to the pelvic region. So it has its origin from the iliac fossa. So the iliac fossa is formed by the ilium, which is part of the pelvic bone. So we really won't go into that. But just know that it attaches, or it has its attachment or origin from the iliac fossa, and then it also joins to insert into the lesser trochanter. And then the quadratus lumborum. So for the quadratus lumborum muscle, the quadratus lumborum is a muscle that is lateral to the psoas major. So once you have the psoas major medially, and then after that you have the quadratus lumborum. So the quadratus lumborum also attaches to the transverse processes of the lumbar vertebra, and also attaches to the inferior border of the medial aspect of the rib 12. So in the rib 12, the part closest to the midline of the body, in its inferior border, serves as an origin, as a point of attachment for the quadratus lumborum, and then it goes as well to insert in the iliac crest. So it inserts in the iliac crest as well. So the muscles of the posterior abdominal wall. The quadratus lumborum is supplied by the anterior rami of L12 to L4, and psoas major still anterior rami. Sometimes we say ventral. Ventral and anterior are the same thing. Ventral and anterior rami of L1 to L3. Psoas minor is supplied by spinal branches of L1, while the iliacus is supplied by the femoral nerve. The femoral nerve is the key nerve that supplies the anterior thigh, as well as, yes, supplies the thigh, the anterior thigh region. So those are all for the muscles that have to do with the abdominal wall. So very quickly, we'll talk about the peritoneum, and we'll look at it under what we call the mesentery, the omentum, and the ligaments. So for the peritoneum is a serous sac. So it is a sac that is serous, and just like we have the pleura, which is also a serous sac, we also have the peritoneum. And the same way the structures invaginate into the pleura, that's the same way structures invaginate into the peritoneum. So what I thought is that in embryology, the lungs grow from what we call the lung board, and then this lung board, it invaginates or pushes into the pleura. And so when it pushes into the pleura, it forms a covering that is closely related to the pleura. It's called the visceral, and that is on the other aspect is called the parietal. So it's the same thing for the parietum. So when the organs of the viscera of the abdomen encroaching or invaginate into the peritoneum, they form what we call viscera. The part of the peritoneum related to them is called the visceral peritoneum, and the part of it that is related to the anterior abdominal wall is called the parietal peritoneum. So now for this peritoneum now, there's a way the parietal peritoneum can form folds, double layers of folds. So these double layers of folds are called mesenteries, and the function of this mesentery is basically just to attach the viscera in the abdomen to the posterior abdominal wall. So this mesentery attaches the viscera to the posterior abdominal wall, and also serves to kind of it serves as a conduit or as a passage for blood supply, nervous supply, lymphatics that go to the organs that they are related to. So under this mesentery, there's what we call the mesentery. So under the mesentery, I always like to emphasize this because it can sometimes be confusing. Under the mesentery, that is under this broad mesentery classification that we're looking at as one of the folds or one of the structures that is formed by the peritoneum, there is a kind of mesentery called the mesentery. So this mesentery that is called the mesentery, that's what's the name. Anytime they're referring to it, they call it the mesentery. It's a type of mesentery called the mesentery. So this the mesentery is actually related to the jejunum and the ileum that are part of our small intestine. So they help to anchor this jejunum and ileum to the posterior abdominal wall, while there's also what we call the mesoappendix. So this is the appendix here. Oh my goodness, I did not label it. So this is the appendix here. It actually looks very small, attached to what we call our cecum, related to our large intestine. So this appendix also has its own mesentery that attaches to the posterior abdominal wall called the mesoappendix. There's also what we call the mesocolon. So the mesocolon is related to the sigmoid colon, and it attaches the sigmoid colon, a part of the large intestine, to the posterior abdominal wall. So these are just a few of the mesenteries that we have in the body. There's some persons also talk about the mesogastric mesentery that attaches the stomach to the posterior abdominal wall. So there's also what we call omentum. So the omentum is basically just another double layer fold of parietal peritoneum that is filled with fat. So whenever if you have the opportunity to do a dissection, you're really able to appreciate this mesentery, especially in people who are on the weighty side, because their greater omentum is large and thick with fat. So this omentum, rather not mesentery, sorry, the omentum, there's what we call the lesser omentum and the greater omentum. So the greater omentum is related to the greater curvature, so it extends downwards to the greater curvature of the stomach and kind of rolls back up and then has relations to the transverse colon. And then for the lesser omentum is more or less related to the lesser curvature of the stomach and extends to cover it up. And so, in line with lesser curvature and also with the lesser and greater so in line with greater and lesser omentum, there's also some ligaments that are important, and these ligaments help to attach two structures, two viscera in the body. Why for the omentum does help to serve as insulation and to just protect and just cover the viscera. So for the ligaments, examples of ligaments, there are many ligaments that we can talk about, but these ligaments typically, you know what they attach from their name. So in relation to the lesser omentum that extends from the lesser curvature of the stomach, there's the hepatogastric ligament. The hepatogastric ligament extends from the liver all the way down to the lesser curvature of the stomach. While there's also what we call the hepatoduodenal ligament. So this hepatoduodenal ligament attaches between the liver once again and the first part of the duodenum. And duodenum is a part of the small intestine. So there's also other ligaments. There's what we call lesser splenorenal ligament, and yeah, there's a lot of ligaments. There's also splenogastric ligaments. So these are all these ligaments, omentums, mesenteries are just structures that are formed by the folding of the peritoneum. So we can call them structures formed by the folds of the peritoneum. So now we're going to go straight into the viscera, and we're going to talk about all these viscera, but there's a way we're going to divide it. So we're going to talk about this viscera based on number one, the primary gastrointestinal organs, or our primary digestive organs, or the primary organs that form the gastrointestinal tract, which are our stomach, small intestine, duodenum, small intestine, and of course under our small intestine we have our duodenum, ileum, and jejunum, and then there's our large intestine, rectum, and our anal canal. And then we're also going to now talk about our accessory organs, our accessory GI organs, our accessory digestive organs, which don't actually allow passage of food, like food doesn't pass through them, but they also help in the digestion process. And those are our liver and gallbladder, our pancreas, our spleen. And then we're going to talk about the kidneys and the ureters, which are related to the posterior abdominal wall and form part of the renal system. So let's quickly look at, we're going to start with the stomach, of course. So the stomach is a continuation of the esophagus. So it is located in the epigastric region, and it's also located in parts of the left hypochondriac region. So yeah, the lesser curvature of the stomach points towards the right, while the greater curvature of the stomach points towards the left. So your stomach comes like this. So it's more in the left hypochondriac region and the epigastric region. And I don't really want to give an extent because the stomach has varying extent depending on the weight of the person and depending on if your stomach is full or empty. So its extent varies. Sometimes it can reach as low as up to the L4, which is the fourth lumbar vertebra. So yeah, let's look at parts of the stomach. So we have the cardiac, there's two ends, there's the cardiac end and then there's the pyloric end. So the cardiac end, of course, tells us that it's related to the heart and it is the part just distal to the esophagus. And then there's the pyloric end that is related to the pylorus. And then you remember we talked about transpyloric plane, that is the line that actually has to deal with part of the division of the regions of the anterior abdominal wall. So yeah, those are the two ends. Then it has two sphincters in these two ends. It has an inferior esophageal sphincter and it has a pyloric sphincter. So these two sphincters help to serve as kind of, I don't want to call them blockades, but they help to regulate the passage and the movement of food so that everything isn't entering all at once. So they actually aid in digestion because they help to make sure that the food that is first in the stomach is digested to an extent before more gets in. And then when we are getting to the small intestine, that the food, the digestive process in the small intestine is optimum. So we're not bombarding the small intestine and the stomach with so much food. So yeah, so there's also two curvatures. There's a lesser curvature and a greater curvature. And as you know, of course, greater curvature is going to be a greater curvature, and the lesser curvature is going to be a lesser curvature. So because of the orientation of the stomach, we cannot say that the stomach has what we call a J shape. So it's a J shaped. Then we also have a body. So the body is between the fundus. The fundus is kind of like a bulging located in its proximal aspect. So then we have the fundus. So between this fundus and the pyloric end or the angular incisure, that's what we have is called our body. So the angular incisure is basically just a bend that is located around here. Angular incisure located around here. It demarcates between the body and the pylorus. So yeah, so these are all the parts of the stomach that are important to us. And of course, it has two surfaces, an anterior surface and a posterior surface. Now, it is related to the esophagus superiorly, to the left dome of the diaphragm superiorly, because I said that the stomach is more in the left than it is in the right. In the left, is related to the left, so the left dome of the diaphragm is located superior to it. And then anteriorly is also related to parts of the diaphragm, to the greater omentum, to the left lobe of the liver. Posteriorly is related to the pancreas, of course. Posteriorly is always kidney. If you don't remember anything, just remember kidney and adrenal gland. So because we said the stomach is towards the left, just remember left kidney and left adrenal gland, or suprarenal gland. That's what I have here, suprarenal gland. And then it's also related to the spleen. So the spleen is posterior to the stomach. So the blood supply. So the stomach gets its blood supply via a lot of things. Firstly, it gets via a lot of arteries. So we have the right and left gastric arteries. We have the right and left gastromental or gastroepiploic arteries. So I prefer gastromental. It's just easier for me. Right and left gastromental arteries, and then there's the short gastric arteries gastric artery as well. So the right and left gastric artery, they supply the lesser curvature. The right and left gastromental artery supply the greater curvature. And then the splenic artery, the short artery, has relation to the fundus. So the short gastric artery and the left gastromental artery are derived from the splenic artery, while the right gastric artery is derived directly from the celiac trunk, and the right gastromental artery is gotten from the common hepatic artery. So for the small intestine now, the small intestine is divided into three parts: a duodenum, a jejunum, and an ileum. But we typically tend to look at the duodenum alone. So the small intestine is partly retroperitoneal and partly intraperitoneal. So anything that's retroperitoneal, whenever we're saying something is retroperitoneal, what we mean is that it's only covered partially by peritoneum. So posteriorly, there's no mesentery that is holding it. Posteriorly, there's no mesentery that is holding it. And yeah, so it only has a partial relation, either a partial relation or it's not even related to the peritoneum at all. So if it's not even related to peritoneum at all, it's called an extraperitoneal organ. So for the retroperitoneal, yes, duodenum is one of the retroperitoneal organs, and it is only covered in its anterior aspect. And the only part of the duodenum that is not retroperitoneal is just the initial 3 centimeters, or what we call the superior part. So what you need to know about the duodenum is that, first of all, it is C-shaped. As you can see, it looks like a C, and then it can be divided into 4 parts based on how it extends or based on its course. So we're saying that, okay, imagine that this is connected to our stomach, and then from our stomach, of course, we have moved towards the right of our body. So the duodenum is located in relation to the right hypochondriac region. And yeah, so it's C-shaped and it's divided into 4 parts. So this first part is called the descending part. This first part is called the superior part. This second part is called the descending part. As you can see, this is superior, this is descending. This third part is called the inferior or transverse part. And then this fourth part is called the ascending part. So we have superior, descending, inferior, ascending. Superior, descending, inferior, ascending. And yeah, so at the point where the pylorus continues as the pyloric part of the stomach continues as the duodenum, there's a curve there. This curve is called the pyloduodenal flexion, and the junction there is called the pyloduodenal junction. Then a flexure occurs. So between the superior part of the duodenum and the descending part of the duodenum, there's a flexure there. A flexure is basically just a curve. A flexure there called the superior duodenal flexion. Then between the descending part of the duodenum and the inferior part of the duodenum, what we have is the inferior duodenal flexion. So they both get their names. One gets its name from superior, one gets its name from inferior. And then we have the duodenojejunal flexure, which also marks the duodenojejunal junction. So the junction between the last part of the duodenum and the initial part of the duodenum is what we call our duodenojejunal junction. And then the flexure, which is the bend that is at that region, is what we call our duodenojejunal flexion. So yeah, what you need to know about this is that the way this C shape of the duodenum is in such a way that it's related to the pancreas at different points. So if we're looking at it from the superior part of the duodenum, the superior part of the duodenum is superior to the pancreas. So while for the third part of the duodenum, the third part of the duodenum is actually below the pancreas. So the pancreas is going to be somewhere around here. While one part is above the pancreas, the other part will be below the pancreas. And then for the second part, the pancreas is medial to it. So that's also you need to know that is important for the relations of the duodenum. And of course, posteriorly, you have your inferior vena cava passing posterior to it, the anti-abdominal wall passing the abdominal aorta passing posterior to it in its third part. So yeah, for the blood supply, the duodenum gets its blood supply from 2 important arteries. It gets from the celiac trunk and also gets from the superior mesenteric artery. So it gets from both of them simply because the duodenum is gotten from the foregut. So I forgot to mention that the way the arterial supply of the viscera in the abdomen is based on their embryological origin. So we have the foregut, the midgut, and the hindgut. Everything from the foregut is supplied by the celiac trunk. Everything from the midgut is supplied by the superior mesenteric artery, and everything gotten from the hindgut is supplied by the inferior mesenteric artery. So of course it tells us that the stomach is gotten from the foregut, and then part of the duodenum is also gotten from the foregut. So it also gets from the celiac trunk, and then part of it is gotten from the midgut. So it gets from the superior mesenteric artery. So for the celiac trunk, parts of it are supplied. We have the right gastric artery, the hepatic artery, the supraduodenal artery. We have our right gastromental. Remember these two, right gastric artery and right gastromental coming from the stomach. And then, of course, why is it going to be right? Because I've already said that duodenum is towards the right, in the right hypochondriac region. Please don't forget. And then we have our superior pancreatical duodenal artery. So if at all you don't remember anything, one thing you should always remember is that the blood supply for duodenum is from superior and inferior majorly. That's the one they're always looking out for. Superior and inferior pancreatical duodenal artery. What it now tells us is that these two arteries, both give branches to the duodenum and to the pancreas as well. So if you now think of pancreas, just remember that okay, pancreas still has the same blood supply as duodenum, superior and inferior pancreatical duodenal artery. And then from the superior mesenteric artery, that's where we now get inferior. So superior is coming from celiac trunk, inferior is coming from superior mesenteric artery. And then also we now have jejunal branches and ileal branches that are going to the jejunum and ileum. But jejunum and ileum, basically, the jejunum and ileum now form that grossly convoluted fold of small intestine that we always talk about. So whenever I think of small intestine, what you just always think about is just a lot of folding, a lot of folding, a lot of folding. So it is formed by this jejunum and ileum. So, and of course, you said that the junction between the duodenum and the jejunum is called the duodenojejunal junction. So, typically, it's mostly always hard to differentiate between the jejunum and the ileum. But one thing, or a few things that can help you to differentiate, is that first of all, for the blood supply, these jejunal and ileal branches that are coming from the supramesenteric artery, they form straight arteries that we call vasa recta, and they form a lot of anastomosis of arteries that we call arcades. So the arcades are formed by anastomosis, a lot of branching. That's why I try to mimic the branching here, and the straight arteries are called the vasa recta. So for the jejunum, they have longer vasa recta and lesser arcades. So they don't have as many arcades as in the ileum, as you can see. And then for the ileum, the vasa recta is short. So that's one thing you can use to differentiate. The vasa recta for the jejunum is longer, for the ileum is shorter. The arcades are more in the ileum and less in the jejunum. If you now decide to go into histologically or internally, when you look at the jejunum has more folds internally in its mucous lining compared to the ileum. And then the ileum has what we call Peyer's patches. So for Peyer's patches are just patches that have immune function. So they help to kind of serve immune function as lymphoid structures or lymphoid structures. So we've already said that jejunum and ileum, they are intraperitoneal because they are held by the mesentery and they are supplied by jejunal and ileal branches of superior mesenteric artery. So lastly, other structures that are related to our primary gastrointestinal organs, we have the large intestine. So I actually apply rectum and inner canal here, but I will not really be talking about it in depth because rectum and inner canal are more in the pelvic cavity than they are in the abdomen. So actually, if you look at the textbook, you see them in abdomen and you see them in pelvis. So I just decided that it's better for us to talk about under pelvis. So yeah, so the junction actually, or rather the ileum, which is a part of the um, small intestine, enters into this part of the large intestine that is called the cecum. So the cecum is named the cecum, and literally what the cecum means is a blind end. So it means that this cecum is not continuing as anything, like it's not continuing inferiorly as anything, just a blind spot. And then what you now have as a continuation is actually going upwards. So instead of continuing downwards, it continues upwards. So this is, although it is the first part, continues upwards and then it is not connected to anything. The only thing that is even draining into it is called the appendix. And the appendix is basically just, some people classify it to be a lymphoid organ, meaning that it has immune functions. But other people say they don't necessarily know the main function of the appendix still. So the appendix is called the vermiform appendix and it attaches to the cecum and it can have different attachments. So it can be posterior to the ileum. I tried to show the ileum entering here. This is the ileum here, and then there's an opening here that I'll talk about very quickly. So the appendix can be posterior to this ileum, it can be anterior to the ileum, it can be below the cecum, it can be posterior to the cecum. So it can show in several ways. What I'm trying to say is that everybody's appendix does not have to be in the same position. So a knowledge of this will actually help doctors so that when they see that this person's own appendix is not here, they will not say this person is abnormal because the appendix has different positions in relation to the cecum. So it leaves us talk about some things like subileal, periileal, and retroileal appendix. So there's an opening in the cecum where the substances, or where the ileum rather, terminates as, and it's basically just called the ileocecal opening. And the junction between the ileum entering into the cecum or terminating into the cecum is what we call our ileocecal junction. And then from the cecum, of course, we go up into our ascending colon. So one thing you should know is that this cecum is intraperitoneal, while the ascending colon is retroperitoneal. So not all parts of the colon are retroperitoneal. So the ascending colon is retroperitoneal, while the cecum is intraperitoneal. So The important things you should know about the large intestine in general is that it has circulations that we call hostra. You can see the way the structure is, and that's one thing you can use to differentiate between it and the small intestine. Aside from the fact that the large intestine is larger and is shorter in length, you can also see the position of sacs that we call hostra, and then there's 3 bands of longitudinal muscles that extend from the cecum all the way to the sigmoid colon, and these are called the tenai coli. So they are not present in the small intestine as well. So the ascending colon is actually 15 centimeters long, and it terminates as the transverse colon. And when it does this, of course, remember that we're moving from the right side of our body. So we have the cecum located in this right iliac region. It goes upwards, and then we get to the ascending colon, which is located in our right hypochondriac and right flank region. And then at this, so this is flank, this is hypochondriac, right, looking at the right of our body. So by the time we get to this right hypochondriac region, it's supposed to cross over to become the transverse colon. And when it does this, it creates a flexure, a bending that is called the right colic flexure. So this right colic flexure can also be called the hepatic flexure. Why? Because it is related to the liver. Always remember that the liver is at the right of your body. The liver is always at the right of your body. That's why the right dome of the diaphragm is higher. Remember. So because it's curving beneath the liver. So we can also call this right colic flexure the hepatic flexure. So then we have our transverse colon. And the transverse colon is by far the longest part of the colon. It's about 50 cm long, and sometimes it is not just straight, sometimes it can bend down into the region of the umbilicus. So the transverse colon, that is, it's also intraperitoneal, and it's held by what we call the transverse mesocolon. So the transverse mesocolon is the mesentery that attaches the transverse colon to the posterior abdominal wall. And then when the transverse colon, then it continues as our descending colon. So the descending colon is the continuation of the transverse colon inferiorly. So by the time we get to this place, of course, we're now at the left of our body, obviously. So the descending colon will be related to our left hypochondriac region and our left flank region. So this descending colon, rather, between the continuation or the junction between the transverse colon and descending colon, there's another flexure that is formed, and this flexure is known as the left colic flexure. So you can also call this left colic flexure the splenic flexure. Splenic because it is related to the spleen. So the spleen is always at the left of the body, and the liver is at the right. So splenic flexure at the left, hepatic flexure, or right colic flexure and left colic flexure. So the transverse colon, or rather the descending colon, is 25 cm long, and it continues as the sigmoid colon. So the sigmoid colon is called the sigmoid colon because it's kind of S-shaped. It curves, and once we get to the sigmoid colon, actually, we are dealing now with the sacral level. So we are around the level of the sacrum, S1 or thereabouts, and we're tending towards the pelvic cavity. So this sacrum is 40 cm long, and it considers as the rectum and the inner canal. And one important thing, this is actually from here downwards is the rectum and then the inner canal. So the important thing is that although the rectum and the inner canal are continuations of the large intestine, they don't have the circulation, they don't have the hostra, they don't have the tenai coli that is present in the in the sigmoid colon and the other parts of the colon. So that's what differentiates it. So for the blood supply, parts of the large intestine are supplied by the superior mesenteric. So from the cecum up to the middle of the transverse colon, supplied by the superior mesenteric artery via the ileocolic artery. Ileocolic artery both supplies the ileum and the cecum of the large intestine. So that's why it's called ileocolic. So even under here, Efeke, right, ileocolic artery, ileal branch of ileocolic artery as one of the blood supplies of the ileum. And then we have the appendicular artery that supplies the appendix. The appendicular artery is actually coming, it's a branch of the ileocolic artery. And then we have our right colic. Remember that this part of the body is where our ascending colon is. So we have our right colic, and we also have our middle colic that supplies part of the transverse colon, or rather supplies the entire transverse colon, and it's coming from the superior mesenteric artery. So once we get to the distal half of the transverse colon, it's now be supplied by the inferior mesenteric artery, meaning that part is coming from the hindgut. So from the inferior mesenteric artery, we have our left colic artery supplying the left part, which is supplying the descending colon, and then we have our sigmoid arteries that are supplying the sigmoid colon. As the earlier stated, we will not talk about the rectum and the inner canal here. We'll talk about them under the pelvis and the perineum. But note that they can be put as both abdominal organ viscera and pelvic viscera. So now we're going to talk about the accessory organs that are related to the anterior abdominal wall.
That brings us to the end of the tutorial session. We hope you've had a wonderful and enlightening time. Thank you once again for joining E-Learning Global. And remember, God, who has always been with you from the beginning, will continue to be with you to the end. My name is Emma James. I'm the Vice President, E-Learning Global BIU Chapter 2025-2026 session. Thank you very much.